Everyone, in this lecture on the gross anatomy of the gluteal region. The gluteal region, posterior inferior part of the trunk, or I can say the uppermost part of the lower limbs. Physically it is a part of the trunk, but functionally it is related to the lower limbs, that is the locomotion and weight bearing. The gluteal region Before talking about the gross anatomy of the gluteal region and understand the anatomy of the region, it is mandatory to understand the bony anatomy of the region. This is the articulated pelvis having two bones, the right and left hip bone or innominate neck bone. The sacrum, lowermost part is coccyx. The iliac crest, the anterior superior and anterior inferior iliac spine, the posterior superior and posterior inferior iliac spine, the greater and lesser sciatic notch. The scale spine is here and the gluteal tuberosity is on the femur. Here it is. The gluteal tuberosity is here, and here it is the scale tuberosity. The acetabulum and the head of the femur articulate to form the hip joint, the ball and socket type of multi-axial joint having flexion, extension, abduction and adduction, and the rotation. So the boundaries of the gluteal region are formed by the iliac crest, the whole length of the iliac crest, this is the coccyx and this is the sacrum. So this is the pelvic bone, the posterior part of the pelvic bone, the sacrum and coccyx. Here I will draw the bone of the opposite side. Articulating on the sacrum. And here is the head of the femur, lesser and the greater trochanter. So this is the bony anatomy of the gluteal region. Here we can see the sacrum, the coccyx, the ilium which is here, the ischium which is here, and pubis is the anterior part of the pelvis. So this is the bony anatomy and this is the gluteal region. The buttocks or the prominences of buttocks are the unique feature of human being. The human being has adopted the erect posture and bipedal mode of walking or locomotion. So there is lot of superficial fascia or panniculus adiposus. The fascia is known as panniculus adiposus, accumulation of superficial fascia and well-developed gluteal muscles forming the prominences of buttocks. So this part which is having prominence of the gluteal muscles and the thick layer of the spinaculus adiposus forming the gluteal prominence, which is spatially rounded or having round contour in women and girls. And this part posterior to the greater trochanter and anterior to the prominence of the buttock is the hip region. So we can divide the gluteal region this part is the buttock part and this part is the hip part. This is the anterior superior iliac spine. We can trace the tuberosity of the iliac crest 5 cm behind the anterior superior iliac spine. We can trace the whole length of the iliac crest in living person because it is subcutaneous, and here it is the posterior superior iliac spine. So this is posterior superior iliac spine and this is the anterior superior iliac spine. This is the tuberosity. The highest point of the iliac crest is at the level of L4 vertebra, and this is used for the lumbar puncture. Lumbar puncture, aspiration of the CSF from the subarachnoid space in the spinal cord at the level of L2 and L3. So L4 is the level for the L2 and L3, and this is the level where the dura mater and arachnoid matter of the spinal coverings ends. The posterior superior iliac spine can be traced by two dimples on two sides of the median plane, and the level of this posterior superior iliac spine is the S2 level, that is second sacral spinal level. One more important landmark, the ischial tuberosity, which is here, the most dependent part of the gluteal region, the ischial tuberosity, and here is the gluteal fold. A transverse ridge or transverse groove forming the inferior boundary of the gluteal region. The median plane is forming the medial boundary, and a line joining the anterior superior iliac spine and anterior ridge of the greater trochanter of the femur forming the anterior boundary of the region. 5 cm lateral and 5 cm above the gluteal groove, we can palpate the ischial tuberosity, and a hand's breadth below the anterior superior iliac spine we can see the greater trochanter of the femur. So again, this is the bony anatomy of the gluteal region, and the boundaries of the gluteal region formed superiorly by the iliac crest. The medial boundary is formed by the median line intersecting the sacrum and coccyx in two parts or two halves. The inferior boundary is formed by this gluteal groove, and the anterior boundary is formed by the line joining the anterior superior iliac spine and the anterior border of the greater trochanter. The bony landmarks are again the sacrum, the coccyx, the scale tuberosity, the greater trochanter, the lesser trochanter, the head of the femur, and the anterior superior, posterior superior iliac spine. The posterior inferior is here and anterior inferior is here. The tuberosity of the iliac crest, 5 cm behind the anterior superior iliac spine. Now I will talk about the fascia, which is covering the gluteal region. Two types of fascia. One is the superficial and other is the deep fascia covering the gluteal region. So superficial fascia, accumulation of fatty fascia or fat in this region. This fascia will cover the gluteal tuberosity and the scale tuberosity and the posterior all part of the gluteal region, and it will form a fibro-fatty cushion over the gluteal scale tuberosity. This superficial fascia is also known as panniculus adiposus. This fascia is having the cutaneous innervation of the gluteal region, which is having branches from the iliohypogastric, subcostal, posterior branch of the lateral cutaneous nerve of the thigh, and the dorsal rami of L1, L2, L3, S1, S2 and S3, and recurrent and perforating branches from anterior primary rami of S1, 2 and 3, which I will talk later. The deep fascia of the region is known as the gluteal fascia. The gluteal fascia is a tough fibrous membrane and splits twicely to enclose the gluteus maximus and the tensor fasciae lati muscle. So enclose two muscles, the gluteus maximus and the other muscle is the tensor fasciae lati. So the deep fascia is splitting twicely to enclose the gluteus maximus and tensor fasciae lati, and this deep fascia forming a tough fibrous membrane to unsheath the gluteus medius muscle. It is unsheathing the gluteus medius muscle and it remains continue with the tensor fascia lata of the front of the thigh and lower part of back of the thigh. Now I will talk about the muscles. The gluteal region is having mainly two groups of muscles. One, the muscles of gluteal compartment having gluteus maximus, so there are three gluteal muscles. One is the maximus, the medius and the minimus. The other group of muscles are short rotators and short muscles and horizontal muscles and are deep to the gluteus maximus muscles and below the gluteus medius and gluteus minimus muscles. These are the piriformis muscle, This is the gluteus maximus, is a strong, bulky, big muscle having most densely fibers or fasciculi. So it is having most densely organized fasciculi in the all body. And this muscle, the piriformis, this is the key muscle of the gluteal region, determining the names of the vessels and nerves. So short rotator is piriformis, the triceps coxae, which is having three muscles. One is the obturator internus, the two gemelli, the gemellus superior and gemellus inferior, and other is the quadratus femoris muscle. Quadratus femoris. There are some other muscles like the uppermost part of the adductor magnus and the origin of biceps femoris, semitendinosus and semimembranosus. But in this lecture, I will talk about only the muscles which are the gluteal muscles, that is the gluteus maximus, minimus and medius, the piriformis, the three muscles of the triceps coxae, that is obturator internus, gemellus superior, gemellus inferior and the quadriceps femoris. First of all, I will talk about the big muscle, the very big muscles or the biggest muscles, the gluteus maximus. This muscle is having multiple origins. So this is the posterior gluteal line, the part of ilium behind the posterior gluteal line. This is the part which is behind the posterior gluteal line. The outer lip of the posterior part of the iliac crest. So this is the outer lip. Fibers are coming from here. This is a rhomboidal muscle or quadrilateral muscle having four lateral borders. Some fibers are coming from the thoracolumbar fascia covering the erector spinae muscle. So some fibers are coming from the thoracolumbar fascia and some fibers are coming from the gluteal aponeurosis, which is covering the gluteus medius muscle. The fibers which are deep and upper are coming from the posterior surface of the sacrum. So these are the fibers which are coming from the sacrum. The deep fibers are taking origin from the coccyx. These are the coccygeal fibers in the lower half, and deep fibers are the fibers which are coming from the sacrum. Some fibers are taking origin from the sacrotuberous ligament. The greater sciatic foramen and the lesser sciatic foramen are converted in greater and lesser sciatic. This is the greater sciatic notch and this is the lesser sciatic notch. Both are converted in the greater sciatic foramen and lesser sciatic foramen. This is the site of the sacrotuberous ligament. So roughly this greater and lesser sciatic nodes are converted in B-shaped foramen, and again this B-shaped is converted in greater and lesser by sacrospinous ligament, which is here. So this is the position of the sacrospinous ligament, and this is the position of the sacrotuberous ligament, and both notches are converted in greater and lesser sciatic foramen. So some fibers of gluteus maximus are taking origin from this sacrotuberous ligament. The fibers, lowermost and deep fibers, are coming from the sacrotuberous ligament, which is here. The fibers are running downwards and laterally and forming an angle of 45 degree with the pelvis. So this is the horizontal line of the pelvis, and these are forming 45 degree angle with the pelvis. The fibers which are superficial and deep of the upper half of the gluteus maximus muscle, and the superficial fibers of lower half of the muscle. Here is the iliotibial tract, which is a modification of the fascia lata, the deep fascia of the thigh. So the superficial and deep fibers of upper half and the superficial fibers of lower half are inserted on the iliotibial tract, which is a modification of the tensor or the fascia lata of the thigh. So 75% or 3/4 fibers of the gluteus maximus are inserted on the iliotibial tract. Finally, the fibers are transmitting the weight or force generated by the muscle to the lateral lip of the linea alba through the lateral intermuscular septum. Listen again, the fibers which are inserting on the iliotibial tract are attached to the lateral intermuscular septum, and finally the lateral intermuscular septum is attached on the lateral lip of the femur or linea aspera. One more muscle which is taking origin from the outer lip of the iliac crest, from the anterior superior iliac spine up to the tuberosity of the iliac crest, are inserting on the uppermost part of the iliotibial tract. So listen again, the fibers of gluteus maximus, upper half, superficial and deep fibers are inserting on the iliotibial tract. The superficial fibers of the lower half are inserting on the iliotibial tract. The deep fibers of lower half are inserting on the gluteal tuberosity of the femur. These are the lower deep fibers of the muscle. So 1/4 fibers are inserting on the gluteal tuberosity and 3/4 fibers are inserting on the iliotibial tract. One more muscle which is inserting on the uppermost part of the iliotibial tract is the tensor fasciae latae muscle. Now one triangular area is left uncovered by two muscles. So this triangular area which is left uncovered and covered by the gluteal aponeurosis and having the gluteus medius muscle and gluteus minimus muscle. The gluteus medius muscle and minimus muscle are covering this triangular area, and this is the safest site for intramuscular injection in the gluteal region. The gluteus maximus is a thick muscle, but under cover of this muscle there are many arteries, nerves and vessels. To avoid the traumatic neuritis, especially to the sciatic nerve, this site is chosen for the intramuscular injection in the gluteal region to avoid the traumatic neuritis. So these are the origin and insertion of the gluteus maximus. Finally, this tract, that is iliotibial tract, is inserting on the anterior border of the lateral condyle of tibia. So finally, weight or force which is generated by this gluteus maximus and this tensor fascial lati muscle is transmitted to the uppermost part of the tibia. So these both muscles stabilize the or steers the knee joint during standing in full extended position of the knee. So action of this muscle: the gluteus maximus actions of the muscle: the most important action of this muscle is it is a powerful extensor of the hip joint. It extends the thigh on the trunk or on the hip joint, and it also extends the trunk on the hip joint. So it is a powerful extensor. But remember, there is no role or almost no role of gluteus maximus in casual or quiet walking. You can put your hands on your gluteal region and can see or the demonstration of the action of the muscle. In casual walking, it is having very limited role during the striking of the heel on ground, during the stance phase or end of stance phase. In swing phase, it is having no role. So extensor of the thigh and the trunk on the hip joint, it is having powerful extensor role in walking uphilling and upstairs. So walking against gravity, the movement of paradox. When we are in sitting position and when we are in standing position and we change our position. If we are in standing position and want to change the position from standing to sitting on chair, the muscle fiber relax very slowly to smoothen the movement of sitting. When we are sitting on the chair and want to change our position from sitting to standing, the muscle acts as a powerful extensor. So movement of paradox. Knee stabilizer or steers the knee. Knee joint during standing in hyperextended position of the knee. The lateral rotation of the thigh. So the actions of the muscle, it is a powerful extensor, and during walking against gravity, that is walking uphilling and the upstairs, it steers the knee joint through the iliotibial tract and it rotates the thigh laterally with the other short lateral rotator of the groups of the muscle.